Okay. Alrighty, let's take a look. Let's make sure everything is okay. Looks like everything's good. Let's just get this on the road. On the road again. Alright, it's sounding good. That's good. Let's make sure we share this on Twitter or whatever. And then we'll get going. You know? Okay. Just grabbing the link, all that stuff. Okay. Go like that, going over Twitter. Okay, looks like we got some people. Hola, Phil. Glad you're here. I'm just going to share this real quick. All right. Just going to tag a couple of folks, see if they're around. If they're not around, no big deal, obviously. And if they are, that's awesome. We'll see, obviously. Okay. And almost posted. And here we go. All right, folks. Well, welcome. Good afternoon, good morning, good evening, whoever you are, wherever you are. My name is Dr. Patrick Lockwood, and this is UnShrink Me. UnShrink Me is a weekly podcast focused on mental health, clinical psychology, psychiatry, and all the related things, the stuff and things of the science and the art of psychology and mental health. So this podcast is a weekly show dedicated to mostly, hopefully, the consumers of services, people who might be seeking out therapy, psychiatry, counseling, Christian counseling, spiritual counseling, couples counseling, whatever you're seeking, this podcast is for you. Because I've seen it in my career so far that there are many people who are well-meaning in the profession who want to help. People who are trying to help. People who have good intentions, who are unintentionally either being not particularly helpful or in some rare instances harming patients. So this podcast is dedicated to you, the consumer of mental health services of whatever kind, so that you have a more well-informed and healthy skepticism of the services you're receiving. I do not want you to sabotage your treatment in any way, shape, or form. I am not here giving you, the individual, viewing specific mental health advice, so please don't sue me, etc., etc. This is just my opinion. And so the reason these opinions exist is because I've seen a lot of people unintentionally do harm in the profession. I've seen a lot of people have very unscientific or unprincipled or unethical views of what it means to do clinical psychology work. And so the goal here of this podcast, in case you're new, is just to make sure everyone who is seeking out therapy, counseling, psychiatry, etc., has the best chance of actually getting what they need from their services. So thank you for joining. I hope this is an interesting episode for you. Today, we're going to talk about why therapy is sabotaged by both the therapist and the patient. Then we're going to talk about the future of psychotherapy. And I have one of my good friends, Jake, to thank for prompting this. I was thinking about doing it, and then he kind of pushed me over the edge. So thank you, Jake. And then we will hopefully end this podcast with something kind of special. So we'll see how it goes. We'll see if we even get to the end. But away we go. And as always, this podcast, the UnShrink Me podcast, is not NOT, sponsored by Celsius. However, I do love this stuff. It is great, in my opinion. It certainly makes everything I do easier and more fun. A little energy, tastes good. So shout out to Celsius. Here we go. So the first topic today, and welcome to everyone watching and listening. This is a tough one because it's a complicated one. So I've spent a lot of time in this podcast so far discussing all the various ways in which psychotherapy can work, What are some things to look out for in terms of transference and countertransference? What looks like a good therapist? What looks like ethics? Things like that. So what we're about to discuss, or what I'm about to share, is a little complicated. So admittedly, I don't want anyone to walk away from this segment of the podcast thinking this is the end of the story. I'm just going to start kind of explaining a couple of different variables and problems that are common in therapy. And after that, I'm going to try to come back to this multiple times throughout the remainder of the podcast, but I'm going to do my best to try and get this at least started. So, sabotage in therapy. Okay? So, first, as always, let me retweet somebody to give them appropriate credit for their ideas. Give credit where credit's due, dear APA style. So first and foremost, we're going to give credit to Jonathan Shedler, whom I respect and I think is useful and helpful online. And I'll read his post, as I always do read, and then I'll start discussing the ideas in the post as it relates to what I think is a more nuanced and helpful way practically for therapists and patients alike to consider. So let me post this real quick. Okie dokie. All right. So Jonathan Shedler, a kind of internet famous therapist, good guy, has a Substack. Check out his Substack. So Jonathan says, this was on 11/28, so November 28th of this year. Excuse me. Here's what Jonathan said on November 28th. He said, patients sometimes sabotage their own psychotherapy, even when they don't realize they're doing it. Sometimes they have no idea, and they're grateful when the therapist tells them. Other times, they seem determined to continue doing it, sabotaging, even after the therapist tells them. This indicates a problem in the therapy relationship that's being communicated in actions, not words. If not addressed and worked through, the treatment is in trouble. Regardless of the meaning, it's always the therapist's responsibility to recognize and work with therapy interfering behavior, not excuse, rationalize, or collude with therapy interfering behavior. What do you think this post is about, and what makes it especially timely? So just for everyone who's listening and watching, I don't want to get into that last question at all because it's probably political, polemical, and I just don't care. But let's talk about specifically the first three statements he makes. So statement number one is patients sometimes sabotage their own psychotherapy, without even realizing they're doing it. So let's talk about that first, then I'll come back to the remainder of his post. So first things first, if you are new to therapy or psychiatry or mental health or whatever, when you're doing psychotherapy, you're having an intentional professional relationship, right? So you do informed consent, you discuss the limits of psychotherapy and confidentiality, you discuss what particular kinds of mechanisms you might use, what techniques, and what the goals of the relationship are, what's included and what's not included, what the boundaries are around communication and all that stuff. So good therapy starts out with a very thorough conversation around informed consent. So just to be clear, my belief, my belief is that a lot of patients are set up to fail in therapy because therapists do a crappy job of explaining informed consent, as I just very briefly talked about. And so patients will unintentionally self-sabotage because they didn't really get a fair chance at looking at the boundaries of therapy and what's up. Looks like my buddy Jonathan's here. Yo, what's up, man? Glad you're here. We're talking about why patients will sabotage therapy. That's the first topic today. And so I'm looking at Jonathan Shedler's post from November 28th, and he said, and I quote, sometimes patients sabotage their own psychotherapy even when they don't realize they're doing it. And so a lot of patients will not realize that they're sabotaging their treatment by doing very simple things, right? So some classic examples of therapy sabotaging or therapy interfering behaviors include, not doing the homework if you agree to homework, or not trying a clinical experiment if you go out after session and you both agree to like trying an assertiveness skill out in your relationships or whatever it is. Excuse me. And so there's a lot of simple things that are symptoms of therapy sabotage. Another classic therapy sabotage behavior is just not showing up to session on time, or refusing to pay for your session, or, simple things like that. Excuse me, I'm so sorry. So it's very commonly the case that people will do simple things or drastic things to sabotage their therapy. So like a classic drastic example of sabotaging your therapy is trying to engage aggressively with your therapist when they're doing something you don't like. So there's all sorts of therapy sabotaging behaviors, and each of them serves a specific purpose, usually for the patient, but also for the therapist, just to be clear. So a lot of times patients do not realize that they're sabotaging their treatment by not complying with something that's already been agreed upon and established, or by, for instance, probably one of the most subtle, insidious, and most common therapy sabotage behaviors. I want to make this extremely clear for everyone. One of the most frequent and common therapy sabotaging behaviors is not being honest with your therapist. If you want therapy to work, you have to tell your therapist the truth. You have to be 100% transparent with your therapist. If you choose not to be, then that is on you. Now, let's move on to the third statement that Jonathan made. I'll come back to the second. He said, regardless of the meaning, it's always the therapist's responsibility to recognize and work with any therapy interfering behavior, not excuse it, collude with it, or rationalize it. So let me give you a crystal clear example of what happens. So sometimes it's the case that people who are seeking therapy or counseling or psychiatry will not tell the whole truth to their provider, right? So I see this all the time where it's like they're talking to a psychiatrist and they're depressed. So depression's the problem, but they're also not telling the psychiatrist about sleep issues and about their caffeine use and their drug use. So they're withholding information from their medical professional that's trying to help them with the specific problem. However, when you leave out important information, you're not going to have the correct solution to your problems. So I want everyone to clearly understand that not telling the truth to your provider is sabotaging your treatment. However, as Jonathan said here, he said, regardless of the meaning of the sabotaging behavior, it's always the therapist's responsibility to recognize the therapy sabotaging behavior and then to do something about it therapeutically, right? So if, just to use myself as an example, if I believe that a patient is withholding from me, it's on me to have a discussion. The onus of responsibility is on me. If I use my so-called clinical judgment and reasoning, and I've determined, either correctly or incorrectly, it doesn't matter. If I believe that there is some idea or fact being withheld from in therapy, it is on me, because I have that suspicion, to say something to the patient. It is not my job to wait around until the patient tells me the truth. So I hope everyone heard that clearly. I'm saying two very complicated things that sound very simple. Complicated thing number one is always tell your therapist or psychiatrist or counselor the truth about everything that's relevant to therapy. But that's not super simple, even though it sounds simple. Number two is it's the therapist's responsibility, it's the professional's responsibility to have a voice and say something seems wrong in our relationship. However, unfortunately, there are many well-meaning people who are cowards who do therapy for a living, unfortunately. And they hide behind professionalism, they hide behind their status or their degree, and they don't have an actual relationship with the patient. They don't say, hey, something feels off. Let's explore this together if you're okay with that. Because it's the therapist's responsibility to take the lead in the relationship. That's why you're being paid all this money to do things. You're not paid to just sit there and listen. That's what friends do, usually. Friends give advice and friends listen. Therapists are supposed to do something. So, I hope that makes sense to everyone. So, one of the most common therapy sabotaging behaviors is withholding information, aka lying to your therapist. And lying to your therapist is not unusual. Many times, sometimes for good reasons, sometimes for bad reasons, and everything in between, you will not trust the professional you're talking to. And I think if you've listened to this podcast even one other time, you realize there's lots of good reasons to not trust people in the profession, because the people in the profession are often really sick themselves. So I get it. It's a perfectly understandable thing to not trust your professional. Also, most people coming to therapy have had really difficult relationships with authority figures in the past, teachers, spiritual leaders, parents, etc. And so because of that, you will project. Patients will often project a type of relationship onto the therapist. So it's like, because I'm a dude and I'm a male authority figure, people will often project their dad issues onto me because I'm a male authority figure guy. And so what that means is sometimes patients will relate to their professionals as if they are that person from their past who hurt them. And then they will use that as an excuse to lie or withhold in the relationship. That's not unusual, by the way. Projection is a very common defense mechanism that all human beings use, especially people who are more hurt from early in life injuries. It's not rare, unfortunately. It happens a lot. So let's be clear. Let's be very, very clear that defense mechanisms of all kinds, are normal in therapy. Projection, like having a transference-based relationship, to be technical about it, where you're treating your therapist as if there's some other person that existed who they remind you of. That's not weird. That's normal in therapy. But it's the therapist's responsibility to help collaboratively explore, discuss, and recognize these transference experiences and then work through them so that the deception you're using can disappear. Now, it would be awesome if you could see and recognize this in advance or while it's happening. But in most good therapy, you're so deep in the woods dealing with thoughts and feelings and issues that you can't always see that. So it's a really good thing to be clear that therapists have the professional burden of responsibility to take the lead when something feels off in the therapy relationship. And one of the reasons for that is because we're supposed to role model being a fucking adult, by the way. And I want to go to the comments here because I think there's some good stuff being said. Jonathan says, I like what Shedler has said about being defended against my own aggression as a therapist. You need a non-pathological level of aggression to confront anyone. I'm going to come back to that sentence, by the way. He continues, confronting self-defeating behavior is part of good therapy. I went through this exact realization in my own marriage and work right after school and started integrating my aggression and still working on it. Okay, so I want to reinforce two things that Jonathan just said here in the chat that I think are really simple but really important. Here's the thing. He said, this is a quote that Jonathan just said, and I want to reiterate it for everyone because I think it's an extremely important quote. This will probably be the clip for today's podcast. Here's what Jonathan said. He said, you need a non-pathological level of aggression to confront anyone. Let's talk that out. Let's walk it out, okay? So, first, you need a non-pathological level. What does that mean, right? So pathological usually means self-defeating, maladaptive, or causing, problematic consequences, right? Generally. So you need to use aggression of some kind to confront anyone. Now let's talk about that because that's complicated. Depending upon what theoretical background you come from, there's a school of thought called motivational interviewing, which some of you have heard about, some of you have not. In MI, there's zero confrontation whatsoever Because what they believe is you're allowed to have feelings, you're allowed to even have aggression, but you're not confronting anyone. You're going to highlight discrepancies as opposed to confronting people. You're going to be curious with the patient about this discrepancy between their behavior and their words, as opposed to confronting them. So it's a different attitude, but a similar goal, if that makes sense, Jonathan. But I want to go back to the aggression piece because people are going to get lost in this, I think. So I just want to reiterate the quote that Jonathan said because I think it's a really good one. I think it's a really helpful one. You need a non-pathological level of aggression to confront anyone. So let's be clear about this. Some degree of, let's call it frustration or sadness or anger or whatever it is, especially a more minor degree of it, is ordinary in therapy. If you are a mental health professional and you have zero feelings about your patient, you're lying, right? If your patient has never done anything to frustrate you or whatever, then you're just an idiot, essentially. So the reality is that regular people have regular feelings even as professionals. And the truth is, the absolute 100% truth is, part of what happens in therapy is you have a professional relationship where the professional you've hired is going to have some kind of reaction, and then it's their professional obligation to understand that reaction, maybe through supervision, maybe through consultation, and then professionally, with ethics and compassion, have a conversation with you. It's not our job to yell at you or confront you like a family member would. It's our job to have a direct conversation about something that seems like an issue in the therapeutic relationship. So that optimal frustration, to use a psychodynamic phrase, is a normal part of therapy. You might call it aggression. That's a word people are afraid of because aggression usually has a connotation of destructive. But there's non-destructive aggression. Okay? Because aggression is a motivating force. It's a motivating emotion. It's a secondary emotion that's goal basically is to push us to do something productive with a feeling of sadness or hurt or confusion. Okay? And so what Jonathan's saying, if I can interpret just a little bit, is a good clinician who notices there's something wrong in the therapy relationship will be frustrated that something is not working in the relationship. And then with that frustration, go do some supervision or consultation, do some self-reflection, look at the patient's experience, look at your experience as the professional and go, okay, why am I frustrated? What do I need to do with this? What's the ethical, appropriate thing to do with this feeling I have so that I can work through whatever the impasse is in our relationship so that we can get back to whatever the goal is for the patient, right? So I hope that makes sense to everyone. There's optimal frustration when you're trying to grow and change. If you're trying to grow and change and everything's happy, then you're a fool, okay? Because growing and changing requires some conflict, some optimal frustration, but also some happiness and joy and confusion and anxiety. It requires all of the feelings, okay? So, thank you, Jonathan, for saying that. But I also want to come back to the very last thing you said. This is very important. I want everyone to hear this loud and clear. He said, I've started integrating my own aggression and I'm still working on it. So I want patients to hear this very, very clearly. The mental health professionals you've hired, counselor, coach, psychiatrist, psychologist, whoever you've hired, these are regular people who are in the practice of therapy, or like in the practice of medicine is the analogy. It's the practice of therapy. So therapy is a practice. It's an art and a science that you get better at doing. So a good clinician is in the middle of working on it. They're in the middle of trying to find a better way to integrate their aggression and use that optimal frustration you're experiencing and seeing if it's the patient's frustration you're feeling or if it's your countertransference you're feeling. Whatever it is, whatever the truth is of your particular situation, that frustration might be part of an important impasse between you and the patient. It might be a you problem or it might be a patient problem. Whatever the truth is, it's your ethical responsibility to notice that and then do something productive with the feeling. And so adults who do psychotherapy go, okay, I'm having a reaction to the patient. I'm having a frustration. I'm having an aggression response, whatever it is. And then what am I supposed to learn from this feeling? What is important about this feeling? Where does this feeling come from? Is it in me? Is it a countertransference thing? Or is it in the patient? Are they projecting? Or is it in them? Are they having a transference relationship with me? Like, what is it that's happening right now? That's the optimal question for all therapists to be asking. What is happening right now? And is it inside of me, or is it inside of the other person, or is it both of us? Because 9 times out of 10, it's usually a little bit of both. It's their transference as the patient, and it's our countertransference as the therapist. And so optimal frustration is about understanding why you need to be motivated to do something to fix a problem or to solve an impasse between two people. That's why Jonathan Shedler said, regardless of the meaning, it's always the therapist's responsibility, just reading his quote again, to recognize and work with therapy interfering behaviors and not excuse their behaviors, rationalize them, or collude with them. So let me go back to the lying thing I was just saying. When patients lie in therapy, therapists will often notice that there's some kind of like gap. There's a tension. There's something wrong between us. I feel like you're withholding from me. And so therapists will often feel pressured to not confront the person because they want to like make sure the patient still likes me. Because if I confront them about them lying, if I highlight the discrepancy, if I'm curious with them, like, hey, something feels off, is everything okay? They're not going to like me. So many therapists are very people-pleasing. They're very agreeable. They want you to like them. But dear consumers of psychotherapy, it is your job to not like your therapist at some point. You know, you should generally like the person that's helping you, but you should also be working through deep and important things where you don't like them because they're saying something that you don't like, or they remind you of someone that hurt you. And that's okay. That's not a sign that something bad's happening. Usually it can be, but usually it's a sign that you're having an authentic reaction about something you need to work through with that therapist. And if your therapist is smart enough and insightful enough, they'll recognize the awkwardness, the gap, the distance, the tension in the relationship. You know, I've worked in Rehabistan for a very long time, unfortunately. And, you know, in Rehabistan, my patients lie to me. You know, people with addiction problems lie like they breathe, you know, and that's part of the disease of addiction. And that's not weird. And so when people who are, you know, struggling with the relationship to intoxication, as my mentor John Daly used to call it, like they're pathologically, romantically attached to being intoxicated, it's hard to tell the truth because they're desperately trying to save that relationship. And so lying is a very normal and understandable way of defending against losing your relationship to intoxication. So deception is part of addiction, and it's not because the person's antisocial. It's because that's how the disease works, so to speak. And so you should never take it personally when someone lies to you as a professional. And if your therapist has a hard time with it, that's because probably they have their own unmet needs that they're not aware of. They don't understand the illness. They don't understand their own countertransference, etc. And that's on them. They have to work through that because they're the professional, right? Now, also, they should have boundaries with you. If you're going to continue to lie to me, I can't really work effectively with you. That's a very healthy and normal boundary in therapy. Now, to be clear, everyone who goes to therapy does something to save face with their therapist. It is not weird at all for people to use so-called white lies with their therapist to make themselves look good. Everyone does it. That doesn't mean it's helpful, though. And hopefully your therapist is smart enough and insightful enough and aware enough to notice the gap, the distance, the tension between the two of you so that you can work through it and have a more honest relationship. Because it's this, as Jonathan said, he's still working on it, right? Like good professionals are still growing and figuring things out and learning to be better at what they do and be more on top of things and assertive more quickly in all these things. And so it's okay for the therapy relationship to not be perfect because it never will be. Also, it's okay for things to get better in your therapeutic relationship. And so, again, just to reiterate, it's really, really important to be clear that therapy sabotaging behaviors are common. They're not uncommon. But good therapists are aware of kind of like the typical types of therapy sabotaging behaviors that patients can do, like lying, like not showing up, like coming late, and all these things. Excuse me. Or importantly, which I haven't gotten to yet, what are the therapy sabotaging behaviors that therapists do? So let's talk about that, shall we? So we've spent 30 minutes talking about how patients can sabotage therapy. Let's spend some time talking about how therapists can sabotage therapy. Boy, this should be good. So, first and foremost, extremely important to me and dear to me is countertransference. So for those of you who don't know, a good general definition of countertransference is when the therapist, the professional, the psychiatrist, the counselor, has specific feelings about the patient because the feelings the therapist is having are about the therapist's experience with someone that the patient reminds them of. So I'll just use myself. If I, as the therapist, sit across from somebody who reminds me of my ex, or if I sit across from somebody who reminds me of my mom, or most commonly, if I sit across from somebody who reminds me of myself in some significant way, then it's entirely possible that I will experience countertransference. Because if I sit across from somebody as a professional, if I sit across from somebody who reminds me of myself, then what can happen is I can treat that patient differently because they remind me of myself, right? So if I treat somebody who's also a professor, for instance, I might be more collegial with that person as opposed to more formal with that person. I might joke around more, whatever it is. And that might be a sign that I'm experiencing countertransference because I'm having more fun and I'm seeing them like myself as opposed to seeing them for who they are. That's countertransference. And so one of the most common ways that therapists engage in therapy sabotaging behaviors is by neglecting to give full attention to their countertransference when it happens in session. Now, most of the time, you can't really recognize that in the moment. Sometimes you can, and I have sometimes, but sometimes you recognize it after the fact, and then it's your ethical duty as a professional to recognize that and do something with it, and do something to help and improve your behavior and treat them more neutrally. So that's one example of how therapists sabotage therapy, by not recognizing and doing something productive with their countertransference. A second thing that therapists do that's therapy sabotaging is they collude with the patient. So collusion, simply put, is when the therapist refuses, either consciously or unconsciously, to have professional boundaries with the patient, right? So if you, as a therapist, agree to a 50-minute session, 50-minute session, but you continually let them stay for 55 minutes, you're colluding with that person. You're not holding to the boundary you agreed to. Now, why you're colluding could be countertransference. It could be projection on behalf of the patient. It could be pathological compassion. It could be like your own feeling of I don't deserve to have boundaries. It could be dozens of things. But when you collude with the patient, when you do something specifically to enable their behavior that's not adaptive for you or them, that's collusion. That's bad. A third way that therapists frequently sabotage therapy is by pretending that they know everything they need to know, which I think is so stupid. But there is no therapist, psychologist, psychiatrist who is so brilliant and so smart that they perfectly understand the patient. I was just talking to someone about this last night. One of the reasons why good therapists don't really give advice is because giving advice is arrogant. It assumes that you know the person's life so well, so perfectly, that you can perfectly tell them what to do, that it will actually help them. But the real truth is, see what I said earlier about patients lying to their therapist or withholding, right? When you're just getting to meet somebody, you don't know nearly enough about them. Most of the time in therapy relationships, it takes 3 to 6 months just to really get to know each other to some significant degree. And so in all reality, you don't know enough to give somebody advice. You need to get to know them better, right? And so the truth of the matter is, if you are so arrogant, and this is disgusting to me because as attentive and observant as I am, as intelligent as I am, blah, 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 I'm very clear that there's so much I don't know about the person I'm sitting across from because it's impossible to know. It's impossible to be so brilliant that you see all the layers of the person, all the games, all the transference issues. Because, how many times are you going to experience patients who seem very forthcoming and transparent, and then all of a sudden, 6 months into therapy, they tell you something they haven't told you yet? Oh, by the way, I was adopted. Oh, by the way, whatever, right? Because patients drop a bomb on their therapist all the time. All the time. And so, it's super, super arrogant to assume you know enough. Because the truth is you don't know enough. So good therapists are humble. They acknowledge that I only know so much about the person I'm sitting across from. And because I only know so much, I can only be so confident in how I treat this person. There's a limit. There's an upper bound, right? And so we can bolster that confidence by having ethics, having an ethics code that we care about, and principles and values that dictate our behavior. But your knowledge alone is mostly useless, especially without ethics and principles. So these are 3 common ways that therapists sabotage therapy: by colluding, by not paying attention to countertransference, and by believing that you know enough to know enough. And that's just never the case. So I hope everyone understands why I'm spending so much time on this, because therapy sabotaging behaviors are very commonly the reason why therapy fails. And because most therapy sabotaging behaviors are common, they happen all the time. And sometimes they happen insidiously in very subtle ways, or sometimes they happen in super big ways. But most of the time, therapy sabotaging behaviors happen in small ways, in subtle ways. And so it's very important, dear patient, if you're a patient or a loved one of someone in therapy, please be very compassionate towards yourself. That trust takes a lot of time and work and effort to build, and that telling the truth is hard. Most people are cowards. Full stop. Most people on the planet right now are cowards. Most people would not get punched in the face for their beliefs. Most people would not walk around and be willing to get publicly scrutinized. It's easy to be a keyboard warrior. It's impossible to go in front of, like I do, like a group of students or rehab or whatever it is, and stand up for what you believe in. Most people don't do that. And I don't even do drastic things. I'm not out there fighting a war or some shit. So let's be clear that cowardice is a spectrum, and a lot of people are extremely cowardice. And so that's normal. It's ordinary to protect yourself, because protecting yourself is what keeps you alive. And that's what's kept the species alive for thousands, if not hundreds of thousands of years. So it's understandable and normal. And so any therapist who arrogantly believes they should tell me everything, that patient perfectly trusts me, I'm so great at my job that they love me and everything's great, that's bullshit. That's just narcissism. And a lot of therapists are narcissists and they're cowards. And so, dear patient, be clear that the person you're sitting across from is a real person who's a regular person, 9 times out of 10. And because they're a regular person, it's okay and understandable that you don't trust them. And it's okay that you're going to work hard, hopefully, to develop a good relationship with your professional. And hopefully your professional is going to work really hard to have difficult conversations, to have fun conversations with you that allow you to grow and go through that optimal frustration and optimal conflict together as a team. Okay? So therapy sabotage, not unusual, number one, not uncommon. And therapy sabotage happens in usually small ways, and these small little things build up over time, and then usually it explodes. Okay? So I hope that makes sense to everyone. I hope that's been helpful, because It's very common, and I feel like I haven't talked about it very much because it just hasn't shown up. But thank you, Jonathan, so much for giving us some grist for the mill to talk about therapy sabotaging behaviors. Okay? And thank you, Jonathan, for all of your comments here in the chat. All right. So, thing number 2 is the future of psychotherapy. All right. So, one of my online buddies, his handle is, what is his handle? His full handle? At CareerFlex, CareerFlex. Let me just repost it real quick, and then I'll talk about it, as I always do. Okie dokie. Okay, here we go. So just today, 1 hour ago, one of my buddies said, my buddy Jake said, if you've been a follower for any amount of time, you know the boys and I are basically the Jocko Willink vibe of psychotherapy community, which is true. You've got to read, yes. You've got to do good psychotherapy, yes. You've got to wear a great-looking cardigan while you do it, yes. I mean, I got a jacket, but yeah. But, ellipses, but, you also have to push your body to limits, to the limit, basically. He says a modern warfighter must keep his body honed for his craft, but would be a fool to neglect his mind. A practitioner of mental health, or excuse me, this is a great sentence. He said, a practitioner of mental healing sorcery, which I think is the appropriate phrase, has to keep his theory and practice absolute, but would be negligent if he didn't stay primal. Let it be iron or humping the mountains, like hiking. It mattereth not. Today I stalked elk for 5 miles in about a foot of fresh snow. I'll catch up with them next time. So my buddy Jake is a little bit of a Joe Rogan type. Lovely guy, I think, personally. But let me talk about something he said here because I think it's super important. So we're talking about the future of psychotherapy, right? And there's a lot of talk about AI and AI therapy. There's a lot of talk about, how is clinical psychology and psychiatry going to change because of technology and science? And the truth is, there's all these really cool drugs coming out, like GLP-1s, like Ozempic and things like that, might actually be helpful for a lot of psychiatric issues, per some of the research that's coming out. And that's super cool because we're identifying more and more cool mechanisms every day. The reason I love science so much is because it's so fascinating. Jonathan says, the people's therapist. I've heard he's never controversial. Our buddy Jake is never controversial at all, especially towards the Swedish or whatever. Anyways, so let's be clear. Like all the cool technological advancements coming our way, I welcome 100%. Let's see what happens. Let's see if we can create brand new molecules that help people because there's a lot of people who are suffering needlessly, right? And I would love, for instance, just to name a very simple for instance, the other day I saw a really cool post from the Journal of the American Psychiatric Association. No. From the Journal of the American Medical Association, their psychiatric division, where they're starting to pair clozapine, which is an antipsychotic, with like Ozempic, basically, I think. And so the idea is these terrible psychiatric medications, terrible because their adverse effects suck so bad and there's so much toxicity to them, like clozapine. Clozapine's excellent at putting a dent in psychosis, essentially. If you're having really serious, negative, tragic auditory hallucinations, clozapine will knock that out for a lot of people. I'm not giving advice. Don't fire me or sue me or whatever. But because of all the terrible metabolic side effects, if you pair that with like an Ozempic, for instance, it actually helps cancel them out. And it might even make the medications more efficacious. Potentially. That's the summary I kind of remember. And so I welcome that. I totally welcome brand new drug discoveries. I totally welcome brand new insights about brain metabolism. So there's this famous psychiatrist named Chris Palmer who talks about mitochondrial health and the brain and how like eating right and healthy diet and healthy metabolism equals mental health. And I'm coming back to this too, so don't lose it. So I welcome all of this biology, neuropsychology, psychiatry, neurotransmission. I welcome all the science that's improving and changing at like a rapid pace thanks to mostly AI. I really do welcome that. I'm all on board with that. And so I want you to understand that nothing I'm about to say contradicts that. So, where is mental health going? Where is the profession going? I believe that the profession is going three directions simultaneously. So, direction number one is what I just discussed. Mental health research is heading in the direction of optimizing your biology, your mitochondria, your digestion, your metabolic health, your brain health. That's one place it's going. There's another place it's going. The other place that psychiatry and psychology is going is relational. So what we're discovering over and over and over again, which Freud figured out 100 plus years ago, is that the quality of your relationship and how you negotiate the relationship is what dictates the outcome. And we've known this for a long time in therapy. So, it's not rocket science to know that the quality of the therapeutic relationship per the patient, from the patient's perspective, is what predicts the outcome. And so many of these new therapies like ACT and DBT and all this and EMDR are really about how the patient views themselves in the relationship with the therapist and how we cope and function effectively. And so there's a relational trend in therapy, which is good because it's time for us to move beyond just skills and all that and move towards, having a healthier, more effective relationship, So that's a good movement. So those are two of the three directions therapy is going. The future of therapy is relational. The future of therapy is technological, and I love that too. But the movement I'm 100% on board for, that my buddy Jake, Career Flex, is talking about, and if you don't follow him on Twitter, he's a good follow if you're interested in mental health and men and stuff like that, is personal. So good therapists take good care of themselves. So I'm going to say this again. Good therapists take good care of themselves. And let me reiterate something he said in his post, because this thing he said is really worth reiterating. This is probably a great quote, and I thank him very much for this quote. He says, "A practitioner of mental healing sorcery has to keep his theory and practice absolute, as I've said before, but would be negligent if he didn't stay primal. Let it be iron, like the gym, or humping the mountains, like hiking, it mattereth not." So I want to spend just a couple of minutes on this because to me, this is crucial. So there's this saying. I don't know how true it is. Yeah, I think it's just, a pithy saying, but my experience has been as a supervisor, as a professor, clinical psychology at the graduate level for 8 years, all these things. Here's what I can tell you for sure. My experience has been that this pithy saying is correct. And here's the pithy saying. You can only take somebody as far as you can go yourself. Right? So just to name an easy for instance, if you're a therapist and you have a bunch of unresolved resentment, then guess what you can't help your patient with? Resolving their resentment. You might very acutely understand how it feels to be resentful. You might have a lot of respect for how hard it is to resolve resentment. But if you haven't done any work on resolving your own resentments as a therapist, then you cannot help those patients manage their resentments. You will not come across as face valid. You will not seem authentic because you haven't done the work yourself. Now, what I want to be very clear about is you don't have to have schizophrenia and have worked through it to help people with schizophrenia. That's not what I'm saying. What I'm saying is that if you are not willing to dig in and deal with difficult feelings and experiences, the patient will not trust you. They will never trust you. because you won't seem face valid. I promise you won't seem face valid. It's impossible, right? And so if you're not willing to do hard work, why should the therapist, or excuse me, if you, the therapist, are not willing to do hard work, why should the patient? And that's true for every type of therapy and every problem, right? If you're treating someone with PTSD, so PTSD is one of the most popular common trauma disorders, right? And if you, the therapist, have your own unresolved trauma that makes you rageful, and you've never dealt with your rage, then how in the world can you help that patient effectively with their rage? Because if you've never learned to manage your own feelings, how are they going to trust you to manage theirs? And so one of the big problems with therapists is they're not primal, to use Jake's word. One of the most important things for good therapists, and if you're a consumer of therapy and psychiatry, I really mean this sincerely, and I don't mean this hypercritically. You want a therapist that's in the best possible shape. You want a therapist that has the best possible relationship with their family and friends. You want a therapist that has the best possible relationship with money. You want a therapist that has the best possible relationship with their own ego needs to feel important and special and all those things. You want a therapist who's quote unquote integrated. They understand so-called their shadow, if we're going to be all Jordan Peterson about it. To talk about aggression again real quick. If your therapist cannot understand or tolerate their own issues, then that therapist is not for you. Now, I don't mean this in the black and white sense, because everyone's on their own journey. What I mean is, there are some people who are practitioners in the profession who are blissfully unaware or in denial about their own issues. And they can't see it, and that person is dangerous. So the thing about being primal, like Jake said, is if you do things like go to the gym, like I do, or go on long runs, like I do, or sprints, like I do, or hiking, like a bunch of people do, or CrossFit, or yoga, or whatever you're doing to be in your body and pushing yourself and challenging yourself. Whatever you're doing to push yourself and challenge yourself will give you new levels of respect for how hard it is to be a person, number one. Number two, what it means to actually have discipline. Number three, to see all of your insecurities and weaknesses. The people who actually push themselves are the ones who understand that there is, to use a Joe Rogan phrase, this is not my phrase, but all of us have an inner bitch, as he says. And I like that because it's true. All of us have that desire to give up. All of us have that infantile, like, I can't handle it anymore. And that's not weird. That's normal and it's human. However, the truth is, that doesn't come from usually a real place of physical exhaustion. It comes from a place of insecurity. It comes from a place of, I don't know if I can handle it. And that's ordinary. That's not weird. But the problem is, many therapists have never dealt with that piece of themselves. And so if you're not primal, to use Jake's word, if you're not doing something to physically challenge yourself, or to intellectually challenge yourself, or to emotionally challenge yourself, you're a bad therapist. If you're not growing, is the short way of saying it, you're not a good therapist. You might help some people, but you're not a good person and you're not a good therapist. And I don't mean that in a harsh way. It's just a reality. Because the whole point of being a professional is to be the one who is taking on the extra effort and working extra hard to be the right kind of role model. Being a good therapist to some significant degree is being a good role model. And I know that I'm not a perfect role model. In fact, I make a joke about that on this podcast by like burping and stuff. But that's a joke. It's an intentional joke. And so the point is, I'm not speaking in perfectionism, idealistic black and white terms. I'm saying that every human being who does the work of clinical psychology, psychiatry, etc., can push themselves to be healthier. And part of being healthier, this new wave of therapists must be the healthiest they possibly can be. If graduate psychology is to survive the AI like coming tidal wave, the only thing you can do is be the best possible person you can be. The be all that you can be school if you're a military person. Because what patients respect is someone who's not full of shit. What patients respect is someone who has been there, done that, and is willing to push themselves. And so in whatever ways you can push yourself, if you're in graduate school right now, if you're an intern right now and you're listening to this, I want you to know that whatever you can do to push yourself to grow is the best thing you can do for your career. Because whatever you're going to do to push yourself to grow, especially in a physical way, to be primal about it, as Jake said, is great. Whether it's sports, whether it's the gym, whether it's running, rock climbing, whatever, I don't care. Yoga's terribly hard. It's ridiculously hard, especially hot yoga. So like whatever you can do to push yourself physically to grow, to have a better relationship with your body, will force you to have a better relationship with your emotions and your mind. And a lot of therapists are lazy. A lot of therapists are very unhealthy physically, and that's not okay. We owe it to ourselves to be the healthiest possible person possible so we can treat patients the best possible, but also so we can be more resilient as professionals. And that's not okay when our professionals are not very resilient. I have an entire, this is probably the only real shameless plug I'll do for my actual business, but like my entire consulting business is about helping people not burn themselves out. That's all I do for a living, is help people not burn themselves out anymore through supervision, consultation, all this stuff. And so genuinely speaking, I'm saying this because I want to put myself out of business. I would love for no one to ever hire me ever again because no one's burnt out. Everyone's getting supervision, the consultation they need, and they don't need me. That's my dream. I don't think it's going to happen, unfortunately, but I think we can start creating a movement. I want everyone to join the movement of being their physically healthiest self possible, to have the best possible relationship with sleep, the best possible relationship with food, and the best possible relationship with exercise and play and sex. I think if you deal with those 5 things as healthily as possible, you will help patients better. You'll be more resilient, you'll be able to do better work, and you'll have more respect for yourself and be able to role model respect for the patient, and they'll respect themselves more. Everybody wins. Let me say this in the blackest and whitest terms possible. If you're a therapist or an intern or a counselor or a psychiatrist, everybody wins when you're healthier. Patients get better, you get better, everybody wins. Everybody wins. And so I can see the future of therapy being 3 things: advancements in technology, like GLP-1s and new meds and things like that, and therapies, physical therapies. It's relational. Let's make sure the relationship is healthy. And it's personal, where you, the therapist, have taken the best possible care of your body so that it reflects on your mind. And I think that is the future of therapy. And I think that if you are in the profession with me and you hold yourself to the highest possible standard with regard to your physical health, it'll obviously benefit your mental health. It won't cure anything, but it'll help. And it'll inspire your patients to be healthier. If you need to lose some weight and you do that while you're doing therapy with someone, your patients will notice, even if you never say anything about it. And how cool is that, right? If you're struggling to eat the right amounts of food and all of a sudden you change your diet and you eat better food, you'll feel better. Your emotions will be better. Your skin will be clearer. All these things, you'll feel better. You'll look better, right? And that's inspiring to people, right? You can inspire people. So I hope that you take the best possible care of yourselves, because life is really short and you shouldn't kill yourself with food and sex and drugs and all these things. You don't deserve that. Nobody does, you know? So I hope that makes sense. I think that's the future of therapy. So today's podcast has really flown by, talking about ways that therapy is sabotaged and talking about the future of therapy, being relational, being personal and physical, and being technological. much more to say about that. That's not the end of it, but I just wanted to start this conversation because I think it's a really good one. So thank you all for coming to watch and listen and share. I really appreciate the folks who came out here to comment and chat. Jonathan and Phil, thanks for being here. And as always, if you thought anything I said was interesting or helpful or challenging or funny or whatever, I encourage you to please hit that like button, share, subscribe, please, because I want to get this information out to as many people as possible so I can help as many people as possible get the most out of their mental health services. This is not me trying to say I'm super smart. This is me trying to help people think about the services they're receiving differently, skeptically, so that they can get more out of it. And if you're a clinician, if you're a professional, I also encourage you to like, share, and subscribe so that you can contribute and challenge me or disagree with me or agree or whatever, or share your experience as some people in the chat do. I really love that. So please, let's all chat. I think everyone's better when we all collaborate together. I think collaboration is the solution. So thank you everyone for being here. And, as always, I like to end this with a joke. And so here we go. So I once had this patient. This guy was, a pretty problematic alcohol user. And so this guy had a really bad relationship with alcohol. He would binge drink a lot and he would gamble and he'd just do a lot of impulsive things while he was drunk. And it wasn't good for him, just objectively, obviously. So anyways, I worked with this guy for about 3-4 months before we stopped working together. And at the end of it, by about the third month, he was sometimes taking a week off from drinking and then back on the, drink and binge thing and doing problematic things. And, he was part of a church, and it worked for him. And he was talking to a couple of his friends at church and they were talking to him about like what he does with his free time. And it occurred to him that he kind of just drank in his free time and it shocked him. So he came back to therapy the next week and it's like, listen, doc, I was talking to my buddies at church and I realized that I only drink when I have free time. I'm like, wow, that's a pretty significant insight. What do you think you want to do about that? I asked him. And so he said to me, I think I want to do something else with my free time. I said, great. What do you think you want to try? He's like, I don't know. I haven't really done much. I kind of did wood shop in school. So maybe I'll just start doing maybe I'll build a chair or something. I'm like, great. That sounds fun. Let's give that a shot. Just kind of like, let's roll with it. So anyways, he comes back the next week, didn't drink. He's starting to, woodwork. He tells me everything's okay. He's kind of making amends for his behavior and all this stuff. By the end of that month, he hadn't had one drink and he wasn't even tempted to drink, interestingly enough. So I said, okay, there's this pattern of not drinking for a month. It's the longest you've gone without any alcohol. Why do you think that is? He said, you know what? Now that I'm doing something with my time that feels purposeful and it's fun because now my buddies come over and we do some woodworking together too, I feel like it's not really worth it to drink because it's not as fun. Like I'm only kind of miserable when I drink. And so I was like, okay, cool. So what do you think is going on with that? He's like, I don't know, but it's just like, I kind of prefer just like having fun with my friends and just doing this woodworking stuff. I was like, okay, cool, great. So like, what are you building? I asked him, I forgot to ask him this entire time. Like, what are you building? He's like, well, I'm building basically a wagon. I'm like, you're building a wagon? That's amazing. And so he said to me, yeah, I never thought I'd build something like this, but it's kind of fun. Just build this big thing. I'm like, cool. Well, it sounds like with regard to your drinking behavior, you're back on the wagon again. All right. Have a good rest of your weekend. I'll see you all next week. Thank you so much.